DBS, deep brain stimulation, brain pacemaker. Very fancy words. Sounds like science fiction, isn't it? Not at all. Ladies and gentlemen, 21st century is a century of the brain. A lot of technological advances has happened in this area to help patients function better. My name is Dr. Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon of Bangalore, India. Today I'm going to talk to you about one of such fancy surgeries, which is called the DBS, or deep brain stimulation, especially in the context of Parkinson's disease. So many of you know, especially those who are suffering from Parkinson's disease or have family of Parkinson's disease patients that you have seen closely, that some of them have symptoms just on one side or one side more than the other side, but many people have both sides equally severely. And so somebody who has bilateral symptoms in both sides of the body which are equally severe, and both sides of the brain has to be tackled at the same time and things like that, then the DBS is one of the treatments of choice for those who can afford. Like I already told you in one of my previous videos, putting a pacemaker in the brain, there is a hardware cost, which is the cost of the pacemaker, and there is a cost of surgery and the cost of post-surgery programming, all of which takes time, money and energy. All right. So DBS this program is the same for those of you who have watched my program on the video on lesioning. We fix a frame to the head stereotactically, the MRI is done, the CT scan is done, the images are merged on the software, on the planning software, the same targets are selected. Now when I say same targets, same way the targets are selected, what are the commonest targets that we use in treating when we do DBS in Parkinson's disease? The commonest target used globally is called the STN, which is the subthalamic nucleus in the brain. STN DBS is the commonest phrase that you will hear being heard as the treatment of choice surgically. The other lesser common but equally good target is the GPI, which you already heard me telling you is a target for pallidotomy. Same spot is used for DBS. In a small subset of patients, like I said in the beginning, when the tremor is predominant, no other symptoms is there, even a VIM DBS is done. And there are variations of this that you call CZI, STN, DBS and things like that. Don't worry into all the semantics. They're all in and around the same area. Different surgeons have found slight spots this side, that side, which gives better results for their set of patients with their skill sets, and they get the results. So when do you do STN DBS? One of the most important things is there should not be any neuropsychiatric symptoms for the patient before surgery. Any patient who's got psychiatric manifestations, either because of syndopa or without the syndopa, STN is not the location or the target of choice, because these symptoms can get worse. The Parkinson symptoms may get better, but by the time the Parkinson symptoms get better with the stimulation, if the psychiatric symptoms gets worse, then there's a problem. And though in those patients, the GPI is a better target to be used. All right. So what do we do? The same procedure, same 40 millimeter holes, but here is the one side. We make both sides at the same time. Same stimulation is happening. Same feedback from the patient is checked to make sure everything is fine. And based on that, instead of burning and coming out like we do in the brain burning circuit surgery, here we leave an electrode inside the brain at the same spot, check it, stimulate it, and then we run both the sides wire into a battery that's kept in the anterior chest wall. This is called an IPG. Implanting of this is usually done under general anesthesia. So first everything is done awake, and then anesthesia is given, and then this implantation is done, usually on the same day. And then usually we wait for a few days. Sometimes immediate post-op, most of the times the battery is not on. In spite of that, patients say that I'm feeling better because we got something called a micro lesion effect. Because of stimulation getting in, you have a micro lesion effect. Patients do get better, and then after the third or fourth day, once the wounds start healing, the battery is switched on, the programming starts. We have a default programming that happens. We wait for some time as the wounds heal and the patient starts getting used to it. We keep programming it with a different There are millions of programs available. Each movement disorder has a set of programs that they think works for their patients. We have to find out what's happening. Patient feedback becomes very important. In all these problems with the brain, there is no meter to check the symptom improvement. There is no way of testing like the blood sugar or blood pressure we check. So the patient's feedback becomes very important. It is the patient's game, a patience of the patient, patience of the doctor, patience of the therapist, patience, PATIENCE. Patience is very, very important in this field. And once we get the right, sweet spot of programming, we maintain that program. If it is a non-rechargeable battery that I have put, like I was telling you, it lasts for 3 to 4 years or maybe up to 5 years in ST and DBS. And in GPI, it's only 2.5, 3 years because GPI takes more current than an STN. So every 3 to 5 years, you have to put a new battery. Now that's the big challenge. Every time it costs many lakhs to change the battery, but that's the way it is. But luckily for us, nowadays, so many companies have brought up rechargeable IPGs, which means that the battery can be recharged percutaneously. So these are some of them have life of 10 years, some of them are claiming to have life up to 25 years. So that's how it is. So every week to 2 weeks, you will have to hang something around your neck and charge this IPG. It takes a few hours to charge. You can be putting it around your neck and watching TV for all we care, like a collar around your neck, and it charges very well. And then you're back in action. So some of the DBS also comes with a small patient programmer that we give it in their hands. So patient can also make a little bit of adjustments which we permit them to do when they're a little highly stressed, to increase the current slightly. When they're calm, they can reduce it slightly, so that basically to do all this to preserve the life of the battery. So that's what DBS is all about. And like I repeat, don't get worried too much. Your expert stereotactic and neurosurgeon, functional neurosurgeon, and the team is very well trained to do all of that. You trust them, you leave it to them. Most important thing is the case selection of who is the right patient for surgery becomes very important. And then if the technique is done well, the results are magical. That's all from this DBS video. Thank you very much. Namaste.